So, our next speaker is a visionary who has transformed the landscape of medical imaging in India. Dr. Harsh Mahajan is a Padma Shri awardee. He has not only pioneered the introduction of advanced imaging technologies, but also established Mahajan Imaging and Labs, which is a beacon of innovation. His early fascination with the power of imaging to reveal unseen truths in the human body led him to pursue excellence in radiology, bringing life saving technologies to the forefront. Today, he'll be talking about the role of imaging in preventing and treating cancer. So, a very warm welcome, Dr. Majan.
Thank you very much, Dr. Rui. It's wonderful to follow after Dr. Thomas, who did a great job. And I will take you through in the next 25 minutes or so, trying to give an overview, a 360-degree view on where imaging is. Of course, it would be sporadic. My attempt is to show images, excite people, and be able to show how imaging, both in screening as well as in treatment, is making a difference. And from my days at MD Anderson Cancer Hospital, which was nearly 3 decades ago, we've seen complete transformation that's happening. And with AI coming in a big way, and in imaging, I believe it's going to make a transformational change. It's really going to hopefully improve treatment outcomes, lead to earlier diagnosis. And we all know that early diagnosis means cure, whereas in stage 3 and 4, we are really struggling for treatment. So I will just share my slides. Are you able to see them?
Um, yes, yeah, you can put
Yeah.
that in the slide in presentation mode.
Yes. I just, can you see it?
Yes.
I
I-
just lost it. I'm not able to see it. What did I?
Do you want me to share the slides for you?
Uh, Let me do it again. If you could do it, that'll be nice because, I come back to R2 images the moment I do slide share.
Yeah.
If we could go to the first slide, please. Yeah. So, imaging in cancer screening and diagnosis. Next, please. So, let's look at the statistics. We all know the C word, and we've discussed not to depress the patient. And we do know that patients who actually take on cancer in a big way and are, really motivated to find it, have much better clinical outcomes. So I agree with the previous speaker that, we need to actually help the patient fight cancer both emotionally as well as medically. Now, we know it's a major societal, public health, and economic problem in the 21st century, responsible for almost 1 in 6 deaths, about 17%, and 1 in 4 deaths from non communicable diseases worldwide. So, NCDs, 25% of deaths from NCDs are because of cancer. Lung cancer was the most frequently diagnosed cancer in 22, followed by cancers of the female breast, nearly 12%, colorectum 10%, and prostate, which again, I think also with the increasing life expectancy, we are seeing these changes. Next, please. What is the role of imaging in modern oncology? It includes cancer screening, detection and diagnosis of tumors, cancer staging, guiding treatment and management decisions, interventional placement of stents, catheters, intravenous devices, and assessing response and complications during and after treatment. So, without imaging, probably we would not be able to proceed not only with diagnosis but also with treatment. Next, please. Cancer screening examinations can be aimed at healthy populations, such as for breast, colon cancer, or those who are at risk for cancer, such as screening for lung and hepatocellular cancers, especially in smokers, looking at lung cancer with low dose CT and hepatocellular cancers in those who have fibrosis and cirrhosis, which predispose to development of HCC. Screening for malignancy is driven by perceived and evidence based risk benefits, reimbursement, published evidence, and societal guidelines. And that's where functional medicine, which is coming into its own, will also increasingly have to give more and more evidence of use of various drugs, even day-to-day drugs like ivermectin, that they are clinically evidence-based, showing a difference when given. Next, please. The primary imaging modalities, and we know X-rays, ultrasound, CT, MR, PET, SPECT, functional MRI. Multimodality imaging is becoming the standard of clinical care. At times, one imaging modality may not be able to provide all answers. Next, please. X-ray, it's been there over 100 and nearly 30 years. Chest X-ray to look for infection or any as an employment check. At times, you're able to pick up, abnormalities even on a simple chest X-ray. And chest X-ray is the highest test in numbers that is done in imaging. If we look at worldwide data, nearly 3 billion chest X-rays are done in 1 year across the world. In cancer diagnosis, chest X-ray and mammograms are often used for early cancer detection or to see if cancer has spread to the lungs or other areas in the chest. Mammograms, of course, look at, and they've been around for a long, long time, and they are used both for screening as well as for diagnosis in those where a lady feels a lump or a doctor feels a lump. This, of course, is an X-ray. If we could go back, please, which shows these multiple, what we call cannonball shadows. These are metastatic deposits in the chest. And here, what you see is osteolytic lesions in the neck and head of femur, which are again metastatic deposits. Next, please. Ultrasound, especially in the developing countries, have become the mainstay. In our country, in India, only doctors are permitted to perform ultrasound, and predominantly it's the radiologist doing it. And because of that, ultrasound has become a mainstay in the early diagnosis as well as in trying to characterize lesions. It can show tumors, but most importantly, it can guide for biopsies or for treating, whereas, doing radio frequency ablations, microwave ablations, all of that. Blood flow can be seen using Doppler, and with that, especially in a cancer setting, we are able to see where are the areas of increased vascularity. Staging accuracy, of course, using ultrasound is not as good, especially in deep-seated lesions. Main indications are confined to superficial organs such as breast, thyroid, and lymph nodes. It has an important role in follow-up, monitoring of liver metastasis, and endoscopic ultrasound in tumor and nodal staging for esophageal cancers, for pancreatic cancers, for gallbladder cancers has come into its own in the last few years. These are examples of papillary thyroid cancer, which is ultrasound is exquisitely sensitive at picking up these lesions and for guiding for biopsy. And this is another example showing how core needle biopsy is done. You can see do it under direct vision, and it's very, very useful. Next, please. This is again something which is done very rapidly, a matter of a few minutes. This is showing the liver with multiple lesions within it, hypoechoic lesions, dark lesions. The liver is studded with metastatic deposits. And this is lymph nodes, which again, the superficial ones can be seen very well. And this shows intranodal necrosis, something that we see in malignancy. But in our kind of setting, we also see this in tuberculosis. So if you say, can ultrasound really differentiate between two, or for that matter, can imaging differentiate? There are, things we use to characterize lesions, but the ultimate arbiter still remains the biopsy. Next, please. Mammography, and I'll spend some time on this in our country as in other parts of the world. This is growing by leaps and bounds. In the urban areas, ladies are at nearly double the risk of getting breast cancer as compared to rural areas, and X-ray mammography is a must. Unfortunately, in our country, we do not have a screening program, and more or less it is left to every individual woman to decide. But at 40 years of age, one should start X-ray mammography and do it annually. Previously, till even 10, 12 years ago, we used to say once in 2 years in those at average risk, and once a year in those at high risk for breast cancer. But that has been restated, and the Breast Imaging Society of India now recommends starting at 40 years of age for all women at average risk doing it annually, whereas those at high risk of developing breast cancer need to start at 30 years of age. Both 2D and 3D forms of mammography are available today, and in addition to regular mammograms, additional spot views may be necessary. Next, please. Uh, and we know, according to patient preferences, at age 40 to 45 years, or 49 years, and in fact going beyond that, it's a must to do this. In India, most cancers, most non-communicable diseases occur about 10 years before they do in the West. And hence, we have to be very, very cognizant, especially when we live in cities. Next, please. This is how the X-ray mammograms look like, and also 3D tomosynthesis is now available, which increases. We were amongst the first in the country to bring in 3D tomosynthesis about, I think it was 12, 13 years ago, and this improves the pickup. Previously, it used to be used only for problem solving, but now it is recommended, it is standard of care even for screening, because the radiation dose is no longer more. And of course, dense breasts, as we know, are more prone to developing breast cancer, and dense breasts also hide cancers when we do screening mammography. And that's where both 3D tomosynthesis as well as the ultrasound are helpful to us in addition to just 2D imaging. Next, please. We have a system of reporting which is consistent called the BIRADS classification, and this actually standardizes reporting across the world, and that is what we used. Here you see a cancer that is there in this region. This is showing spiculated margins, very typical, and this is what we see in the same case on ultrasound, where you see irregularity of the margins, and this is very, very typical. And using ultrasound guidance, you can actually put in a needle and do a biopsy. And the same we see on a MR mammogram. MRI today is the most sensitive technique to diagnose the lesion as well as to see multicentric lesions. At times, you may have bilateral breast lesions, and that is where, once a diagnosis is made, or if a patient is at high risk, they are sent for a MR mammogram. MR mammogram is not the primary modality for use, except in those who are at high risk, where it is recommended that at 30 years of age, you can, instead of doing an X-ray mammogram, because young ladies have dense breasts and you can miss lesions in them, instead of doing X-ray mammography, you can start with an annual MR mammography. Next, please. CT is the mainstay modality in oncology. It is useful not only for diagnosis but for guidance for interventional procedures and to improve tumor visualization. Current key applications in the chest present an extent of lung lesions, pleural or mediastinal abnormalities, liver, biliary tree, pancreas, kidney, adrenal glands, small bowel, and colon. In the brain and spine, actually, it is MR that has taken over. Similarly, for breast, for prostate, and but CT still remains mainstay of imaging in cancer. Next, please. It also plays a major role in radiotherapy planning. Next, please. MR is the imaging technique of choice, like I said, in the brain and spinal cord, musculoskeletal tumors, particularly sarcomas of the extremities, useful in assessing and staging head and neck, breast, prostate, adrenal gland, and female pelvic tumors, for intraoperative guidance, virtual endoscopy using multiplanar reconstruction, for image guided brain surgery to locate tumors and key structural components of the brain. MR is safe so long as there's no metal in your body, and even if the metal is non ferromagnetic, there is no problem. MR is safe for pregnant women and kids. There is no harmful radiation for MR, and where you can switch from using a radiation giving modality to a non radiation one, from X-ray to ultrasound or from CT to MR, provided we don't actually lose diagnostic accuracy, it is better to use a non-ionizing imaging technique. Next, please. Advantages, of course, are improved lesion characterization, improved identification of normal anatomy, particularly within the central nervous system. The risk of anaphylaxis is low. Next, please. This is in the brain. This is a glioblastoma. Usually, with or without treatment, patients in this category do not survive more than 12 months. And that's a meningioma which lies outside the brain. As the name itself suggests, this is from the meninges lining outside the brain. And so this causes compression of the brain. Next, please. These are multiple metastatic deposits in the brain, and MR with contrast is the modality of choice. And this is a tumor, a ependymoma within the spinal cord, which you can see here very nicely depicted after injection of contrast, and there's edema around within the cord. Next, please. Extremity, where you see this osteosarcoma. And what MR also helps, and MR is the gold standard in this, is seeing skip lesions. Here you see another lesion, which is separate from this lesion in the lower end of the femur, and this is brought out. And this is a CT scan for showing metastasis within the lungs. And here I'd like to say that MR is not very good at visualizing the lungs. At times, an X-ray may show more than what an MR may show, and hence, it is important that we don't overuse a modality. Just because we think MR is the best modality in the world, we use it, whereas in the chest, even a chest X-ray is better. Next, please. Liver lesions, this is a pre-contrast CT, that is a post-contrast CT showing liver metastasis. This is a MR pre-contrast and post-contrast. MR is the most sensitive technique to pick up abnormalities within the liver and also is able to characterize lesions very well. Next, please. Imaging advances, novel functional and metabolic imaging tools have been there for a long time, but really came into their own in the last 10, 15 years, and we will talk about them. Next, please. This is, on MR, diffusion weighted imaging, which is able to show and pick up abnormalities very well at the cellular level. Next, please. This is, there's an interaction of intracellular, extracellular water molecules, and that's what this is able to show. Next, please. And based on that, we are able to pick up abnormalities very well. And these are actually going down to the molecular level, and we are able to, this is part of functional MRI. Next, please. Then we have diffusion tensor imaging, which is able to show various tracts within the brain. Next, please. And this is very important because when you are going in for surgery or radiotherapy, if you injure the white matter tracts, which actually communicate between different centers in the brain, you may do more harm than good. And so using diffusion weighted imaging, diffusion tensor imaging, we are able to see these tracts, and a surgeon is able to actually preserve them on surgery. Next, please. Again, next, please. Functional MRI also, when we talk of what is known as blood oxygen level dependent imaging, where you are able to see brain activity. I move my fingers, I can see which part of the brain gets active, and when tumors are in close proximity to these areas, we use bold imaging to be able to show the brain activity in relation to the tumor, and the surgeon then is able to preserve this center and not harm it. Otherwise, the patient would become hemiplegic after surgery. Next, please. So, putting all these things together, now the surgeon can, with functional MRI, with delineation of white matter tracts, with diffusion weighted imaging, with contrast, you're able to do a much better surgery and with much lower risk of causing some side effects, some damage to brain tissue. Next, please. Nuclear medicine imaging, PET and SPECT, and they've come into their own. We'll talk about that. Next, please. These are, again, molecular and metabolic imaging techniques. And 18F FDG PET is the mainstay. Next, please. And the indications for its use are growing. Next, please. We also are able to use contrast enhanced CT along with this. Next, please. And so, in a way, it gives the best of both worlds. This is a nasopharyngeal carcinoma, which you're able to see here. This is a CT scan after contrast, and you can see that it's very difficult to delineate the tumor from normal tissue. Whereas when we do the PET along with, you can actually see the tumor very well, where its demarcation is, and also when we fuse the two together, you're able to get the best of both worlds, structural imaging along with functional imaging. Next, please. Yet another case, a parotid cancer. Next, please. Esophageal cancer here with the metastasis within the bone. This is how a PET scan raw image looks like, and this is what it looks like after it's been reconstructed with the CT scan. Again, a case, of lung cancer with metastasis all over the body. This is the fused image. Next, please. Another case. Next, please. It's also used for pre-treatment staging. And then even after the second cycle of chemotherapy, we are able to see changes. In fact, it's said that after giving chemotherapy, within 12 hours, you can see metabolic changes which can be picked up on CT, whereas structural changes may take 6 cycles, 8 cycles before you can be sure whether a drug is acting or not. Next, please. Next. Whole body imaging modalities, there are multiple. Next, please. Now, there is increasing use globally of using whole body MRI screening for early diagnosis for cancer, for other abnormalities in the brain, and also for using it for as really a poor man's PET CT. PET CT, remember, gives radiation. Whole body MRI does not give any radiation. There are still ethical issues involved in it, but if a person by choice wants to get it done, how can we stop him? Next, please. Next, please. Next, please. Next, please. We've spoken about this. Next, next, next. Colorectal screening, and we'll talk about this. This is something done once in 5 years in the US for the entire population, covered by insurance. And on a CT scan, you're able to pick up very well, and you can do a virtual colonoscopy and pick up these polyps. This was a benign polyp which was picked up on a CT scan. Next, please. Screening for lung cancer, like I said. Next, please. In smokers, an annual low dose CT is recommended, and this is able to, pick up, reduce lung cancer mortality by about 20% and overall mortality by 6.7% compared to those who were screened using a PH chest X-ray only. So for lung cancer screening, yes, please. Next, please. CT is the modality of choice. We give a very low radiation dose. Next, please. Hepatocellular carcinoma. Next, please. Again, next. In a cirrhosis setting, hepatocellular carcinoma picked up and then can be treated. Next, please. Now, AI actually is coming in a big way, and integrated diagnostics is coming in. Next, please. And here I would really be ending with this slide where, diagnostic departments, diagnostic modalities actually work in silos. The pathologist does his own bit, the microbiologist, the biochemist, then we have the radiologist, the nuclear medicine specialist, the genomic specialist, all of that. And, these silos, I believe, need to be broken. We need to talk of integrated diagnostics, because what the physician who's treating needs and what the patient needs is exact diagnosis. And as data increases, as newer and newer tests come in, it's very difficult unless something brings them together. And I do believe that AI, next please, will be doing that. I'm just finishing. Integrated tumor boards are there, and we will have one diagnostic workstation where everything will be represented: pathology, radiology, nuclear medicine, biopsy, everything. Next, please. Next.
That's the last one.
Okay, I can end here. And also, things like this, where everything is represented along with the clinical findings on one screen. Next, please. Next. Radiogenomics. Next. Next. Uh, uh, now, we have next built this integrated diagnostics institute in our center. Next, please. Next, please. So I would say that imaging is the mainstay of screening, of early diagnosis, of seeing the extent of cancer in the body, and we need to use multiple imaging modalities. But what I would suggest is using the appropriate and the most minimum of imaging that is necessary, so that one, the patient doesn't need to go again and again. Number two, doesn't need to spend money on multiple tests when one test can give you the exact diagnosis, and also reduce the radiation dose to the minimum. Of course, with AI coming in now, radiation doses have got tremendously reduced in both PET CT and in CT itself. Thank you very much for giving me this opportunity. It was a huge topic. I've tried to do the best that I could.
Yeah. Thank you, Dr. Mahajan. I think you have very well put across a lot of clarity on the kind of imaging that can help in different kind of lesions. As you rightly said, there are so much of diagnostics done when it comes to, kind of really diagnosing a lesion. So I'll take maybe one or two questions. So one of the question is, given that mammography has exposure to radiation, so would thermography be a better option when it comes to
See,
screening?
thermography has been around for 4 decades. It never could, prove that it's anywhere as good as X-ray mammography. And X-ray mammography, even in the olden times, when we used to use much more radiation, when it wasn't digital mammography, it has been proved beyond doubt that it does not cause cancer. That was with the older machines. Now, with the full field digital mammography machines that are there, the radiation doses have come down dramatically. And so there is no fear of X-ray mammography. And hence, thermography, if it were to come into its own, and there are attempts at improving thermography, maybe at a population level, if you're able to take the tool from village to village, from district to district, you could do that. But ultimately, in those where you find abnormality, you will still need to do X-ray mammography. So I think we should not play down the role that X-ray mammography plays as it is. Ladies are very shy in our country to come for X-ray mammography. And if we start talking like this about the radiation, there is no radiation danger.
And how about the inconvenience of, the pressure applied during the process of?
See, the pressure applied once a year, and now, we use machines from Fuji where the machine itself has inbuilt intelligence and it retracts back if the compression increases. So, even that, I think for diagnosing cancer, which is not palpable, I think that little bit of discomfort is well worth it. 20 to 25% reduction in death rates.
Great. All right. Thank you so much, Dr. Mahajan,
Thank
for
you.
all the insights. Thank you so much.
Thank you very much.